Okay. For those who are new here, I have been reading the first aid for the USMLE Step 2 and I'm reading Obstetrics. We have completed all these topics, right from abortion up till the normal delivery, we completed abnormal labor and delivery. We have completed up till fetal malpresentation. So if you're new here and you want to read this along, you can watch the earlier episodes. Now we will continue with umbilical cord prolapse in the abnormal labor and delivery series. And then we might complete this, continue with puerperium in a separate video and lactation video. So hold on. For those who have come right now, this is a very efficient way of reading the first aid USMLE, which is always and always an imperative first step for you to start reading, whether you are an undergraduate in MBBS or you're appearing for USMLE. Somebody who is giving a GP registration examination and not from the specialty, for example, myself, I'm an internal medicine specialist and I'm taking the DHA GP exam for registration. And it will be helpful for MRCP GP and other general practitioner exams as well. So without holding you on, let's start. We will be doing umbilical cord prolapse, which is on page number 461. To start, come on this page. You are using a hard copy. Umbilical cord prolapse. Now this occurs when cord presents head of the fetal parts and protrudes through the cervix, considered as an obstetric emergency. Risk factors include rupturing membranes without engaged fetal head part, malpresentation, prolonged labor, and polyhydramnios. Diagnosis: you will visualize or palpation of the umbilical cord ahead of fetal presenting part can be accompanied by abrupt, severe, prolonged deceleration. So you will actually visualize it. You can see the cords hanging down the vaginal orifice. And treatment, we need to manually elevate the presenting part, call assistance, and prepare for emergency delivery if you can. Okay? See that if it's not hanging around the neck of the baby, the neonate. Shoulder dystocia. Now, this is rare. It occurs in around 0.6 to 1.4% of deliveries in the United States. Risk factors include obesity, diabetes, suspected fetal macrosomia, a history of an infant with macrosomia, post-term pregnancy, and a history of prior shoulder dystocia. We can see somebody who's got a large baby, themselves are large, having metabolic syndrome, or their post-term pregnancy. Those are the cases where this shoulder dystocia is happening. Diagnosed by prolonged second stage of labor, retraction of the head from the perineum, that is the turtle sign. In the event of dystocia, the following maneuvers may be attempted. You can do the Mac Roberts maneuver, which is, let's see what is this. So there's leg elevation of the mother and application of suprapubic pressure. Flexing the hips against the abdomen. The leg positioning illustrated here can be used to assist in a delivery where the infant is at risk for shoulder dystocia. Suprapubic pressure may cause reduction of the shoulder dystocia. You can see the shoulder dystocia there. And through adduction of the anterior shoulder, fundal pressure should be avoided in shoulder dystocia as it may cause further impaction of the anterior shoulder against the pubic. Application of suprapubic pressure. Note that fundal pressure is contraindicated here, so do not press this area. Internal rotational maneuvers have been applied. Now, this is used if external maneuvers have failed to reduce the dystocia. These maneuvers reduce the diameter of the fetal shoulder girdle through reduction of the anterior shoulder towards the fetal back or reduction of the anterior shoulder towards the fetal chest. By the finger of one hand if reduced anytime. So these are maneuvers to reduce the diameter of fetal shoulder girdle through abduction of the anterior shoulder towards the fetal back. Delivery of posterior arm. Intentional fracture of the fetal clavicle. Proctoepisiotomy. Zavanelli maneuver. So you just need to know the names in most of the exams. Manually pushing delivered fetal head into the uterus and taking patients for cesarean section. Excessive traction on the fetal head to deliver the anterior shoulder can result in stretch injuries to C8 to T1 brachial plexus, including Horner syndrome, Erb's Duchenne palsy, or Klumpke palsy. These brachial plexus injuries usually resolve spontaneously. Episiotomy. This is the surgical extension of the vaginal opening into the perineum and can be median or mediolateral. Complication, extension to the anal sphincter, third degree or rectum, fourth degree, more common with midline episiotomy. There is bleeding, infection, dyspareunia, rectovaginal fistula formation can occur in this. Routine use of episiotomy is not recommended, however, it is routine. Uterine inversion, an uncommon cause of postpartum hemorrhage. This occurs when the uterine fundus prolapses through the cervix and vagina and can often be visible as a shaggy mass protruding from the vagina. Shaggy mass protruding from the vagina is your uterine inversion. The fundus is no longer palpable and the patient is usually experiencing severe abdominal pain. These causes include excessive fundal pressure and traction on the umbilical cord. Treatment includes discontinuation of uterotonics, manually replacing the uterus, and monitoring hemodynamics. Uterine rupture, a very rare but life-threatening complication that may occur in pregnant patients with cesarean section, especially the vertical cesarean section or other uterine surgeries. This may result in postpartum bleeding. Loss of fetal station is pathognomic for this condition. And fetal parts may be palpable in the abdomen but not in the vagina. Treatment involves emergent laparoscopy. Now we come to puerperium. I think we'll continue in the next episode so that we can combine puerperium and lactation and all these. If you haven't subscribed yet, please do subscribe to this channel and share it with somebody who